Hi, everyone. My name is Lovely Thomas. I'm working as a registrar in obstetrics and gynecology in Calderdale Royal Hospital. And I'm very grateful for the SciTech series for providing me a platform to present my oral presentation. So my presentation is about a case of spontaneous expulsion of fibroid after emergency C-section. Next slide, please. So my case is, I'm presenting a case of a 41-year-old, Gravida 5, Para 4, previous 1 C-section, followed by 3 VBAC, that is vaginal birth after C-section. And this lady had a history of previous preterm deliveries. In this pregnancy, she was a late booker at around 18 weeks. Hence, the expected date of delivery was calculated from the head circumference from the scan done at 18 weeks. Her BMI, that is body mass index, was 37, and VTE score, that is venous thromboembolism risk score, was 3 for her age, parity, and BMI. In this pregnancy, the current pregnancy was complicated by submucosal fibroid of size 7.5 into 6 centimeter, which was clear of the internal os. And this lady had around 3 scans in the pregnancy. And throughout the pregnancy, the fibroid remained almost stable. This pregnancy was uneventful till 36 weeks. And at 36 weeks, she presented to the emergency service with preterm labor pain. And on examination, she was in established state of labor. That is, she was fully effaced and 5 centimeter dilated, and it was a breech presentation. Next slide, please. This is an ultrasound image showing the submucous fibroid, 7.5 to 6 centimeter in one of her scans. Next slide, please. So after examination in the emergency service, we gave her option of vaginal delivery and C-section. She opted for C-section, and hence she was quickly shifted to the theater because she was multiparous. And she progressed quite quickly. So in the theater, when we re-examined her, she was fully dilated and the breech was at -1 station. And in the theater, the CTG, the CTG monitoring was pathological, and the breech was, it was not at spine, it was above the spine. So because of the high station of the presenting part, the decision was made for a category 1 C-section. Emergency C-section was quite challenging due to previous additions, multiple fibroid, and atonic PPH. Atonic PPH was managed with uterotonics. And the estimated blood loss at the end of the surgery was 1.3 liters. She was shifted to the recovery and later to the postnatal ward. But later she developed severe abdominal pain and heavy PV bleeding around 9 hours after the C-section, which was not settling with uterotonics, tranexamic acid, and the normal pain relief medication. Next slide, please. So because of the heavy bleeding, she was taken back to the theater for examination under anesthesia and management of PPH. Examination under anesthesia revealed a prolapsed fibroid of size 7 into 5 centimeter into the vagina, which was removed by simple traction. And once the fibroid was removed, the bleeding settled all on a sudden. And the uterine cavity was checked for any retained placental tissues, but it was empty. And the C-section suture lines were also intact. So initially, we thought of putting a Bacteri balloon for managing the PPH, but once the fibroid was removed, the bleeding settled. Hence, we didn't insert the Bacteri balloon. So the total blood loss was 2.2 liter. And she was given 3 units of packed blood cells postnatally, and she was discharged on postnatal day 3. Next slide, please. So this is a picture of that prolapsed fibroid, which we have removed by simple traction through the vagina. Next slide, please. And we have sent this for histology, and the histology report showed leiomyoma. So this case underlines the importance of considering fibroid as a cause of abdominal pain, not only during pregnancy, also in the postnatal period. Next slide, please. So we all know that the uterine fibroid or leiomyoma, it's the most common benign pelvic tumor in women of reproductive age group. The risk factors of fibroid being age, ethnicity, family history of fibroid, long interpregnancy interval, and early menarche. Now, as more and more women of advanced age group get pregnant, we are finding more of fibroid complicating pregnancies. Uterine fibroid are present in 2 to 11% of women during pregnancy. And the complication associated with fibroid during pregnancy are preterm labor, preterm premature rupture of membrane, spontaneous miscarriage, placental abruption, malpresentation, increased C-section deliveries, and postpartum hemorrhage. So in our case, our lady went into preterm labor at 36 weeks, and the baby was in breech presentation. So there was malpresentation, and she had an emergency C-section for malpresentation and also for the pathological CTG, and she had a major obstetric hemorrhage. Next slide, please. So in most cases, the fibroids are asymptomatic or they are undetectable clinically during pregnancy. So there is difficulty in differentiating fibroid from physiological thickening of endometrium. Hence, there is underestimation of the prevalence of the fibroid. Ultrasound studies have shown that 20% of the fibroid enlarged during pregnancy due to the effect of estrogen in pregnancy, and a similar proportion, they decrease in size. There are prospective studies with the use of ultrasound to follow the size of the uterine fibroid throughout the pregnancy, which show that majority of the fibroid, that is 60 to 70% of the fibroid, they do not demonstrate any significant change in volume during pregnancy. So in our case also, the size of the fibroid remained fairly stable. Next slide, please. The red degeneration of fibroid occurs when the rate of growth of the fibroid outstrips its blood supply. So the clinical presentation, the woman usually presents with severe abdominal pain that is managed with pain relief medication. In our case, this lady didn't have any admissions with abdominal pain. It might be because of the steady size of fibroid during the pregnancy. Next slide, please. So the expulsion of fibroid could be explained by the contraction of the uterus postnatally, thus pushing the submucous fibroid towards the os and thus interrupting the blood supply to the fibroid. So in our case, during the C-section, we might have interrupted the blood supply of the fibroid, and together with the uterine contraction in the postnatal period, it might have dislodged into the vagina. In the postnatal period, that is around 9 hours after the C-section, our lady was in excruciating pain. She was asking for more pain relief, and at one point we have to give her morphine. So she presented with severe abdominal pain and heavy PV bleeding. So one of our differential diagnoses was uterine inversion, as uterine inversion can also present with severe abdominal pain with strong bearing down sensation along with PV bleeding. Next slide, please. So since it's an unusual presentation of fibroid in the postnatal period, we reviewed the literature. And while we were reviewing the literature, we came across a few cases of fibroid expulsion after normal vaginal delivery. And we could see only 3 cases of fibroid expulsion after C-section. So the first case was reported by Murakami et al. In 2007, where they describe a case of fibroid expulsion 16 days after C-section. And this lady presented with moderate vaginal bleeding, fever, and vaginal discomfort. And in this case, part of the fibroid had been sloughed off into the vagina. But later on, they had to do an abdominal myomectomy to remove the entire fibroid. The second case was described by Sago et al. In 2015, they reported a case of spontaneous expulsion of fibroid 6 weeks after C-section, and they took the lady to the theater for examination under anesthesia, and they removed the fibroid by twisting off the pedicle. And the third case was described by Zhang in 2018, where they have described a case of spontaneous expulsion of a huge cervical fibroid 2 weeks after C-section. So when they examined this lady under anesthesia, they couldn't reach the root of the mass, and the mass was removed by blunt and sharp dissection. Next slide, please. So the learning point from this case is, nowadays as women delay their childbearing age group, there is more prevalence of uterine fibroid during pregnancy. So we should be aware of this complication in pregnancy and also in the postnatal period. So when a lady who had fibroid in the pregnancy, in the postnatal period, they come, if they present with heavy PV bleeding and severe abdominal pain, the expulsion of the fibroid should be one of our differentials. And also in the previous 3 cases which I have described, they have came after 2 weeks after C-section, and some of the ladies have presented with features of sepsis. So we need to bear this in our mind while treating our ladies. Next slide, please. So these were the references from where I have I referred these journals to prepare my presentation. Next slide, please. Next slide, please. Thank you. Thank you.